right, thank you. I really appreciate the invitation and the chance to talk about this topic. And the good news is that we're in an era now where emerging options in radiation therapy, there's a lot to talk about. And I'll really be focusing just on advances in radiation therapy itself and not even on synergistic combinations with systemic and novel agents, immunotherapies, and so on, which, I could easily take up the entire morning talking about all of that if given the opportunity. These are my disclosures. And so I'll just briefly cover the established role of radiation therapy in lung cancer and then go on to talk about the evolving role of radiation in lung cancer by different stages: locally advanced, where arguably the role of radiation has been most established, and then also early stage, where there's now a lot of new data, and advanced stage. So if we look at both treatment strategies and outcome by stage, we see that for localized lung cancer, historically, the primary therapy has been surgery, and the outcomes have been reasonably good with survival rates in the 50% or so range. Then as we move to regional disease, radiation therapy becomes a primary treatment modality, generally in combination with chemotherapy. And outcomes are worse. And then in advanced disease, the primary therapy has been systemic, and the outcomes are correspondingly much worse. And of course, the outcomes are reflecting the stage of the disease as opposed to the efficacy of the therapies per se. The overall outcomes across the board in all stages is quite poor in lung cancer. And of course, that's because presently, at diagnosis, very few patients are diagnosed with localized disease, and the majority, in fact, are diagnosed with distant disease. So historically, the most curable stages of lung cancer have been diagnosed least often, and only a minority have been potentially curable by radiation therapy. And even in those, the efficacy has been modest. Often, treatment with radiation therapy is palliative, and it could be argued that the clinical impact of radiation has been most important in palliation of symptomatic lung cancer. However, radiation has changed dramatically, and I'm going to argue that the advances now give radiation potentially a role as definitive therapy in every stage of lung cancer. Not for all patients in every stage, but a role in every stage. So let's start with locally advanced. That's where the role of radiation has been most established historically. And the main advances technologically have been in highly conformal radiation therapy. So the goal of the technology development has been to make radiation more conformal, more focused on where the cancer is and avoiding the normal structures. So this is done by using multiple intersecting beams that are individually shaped, and the high-dose regions will conform to the tumor and spare normal tissues. And this allows very sharp dose gradients to be achieved, and I'll show you examples of that. And so terms you'll hear about are intensity modulated radiation therapy and kind of a family of technologies. And what's really enabled this in recent years has been primarily CT-based, but also other imaging-based computerized treatment planning to optimize the delivery of radiation, and then the integration of imaging in many forms that we generally refer to as image-guided radiation therapy. With respect to image guidance, we do this there's a couple of stages at least where it's important. At the time of treatment planning, we use imaging to help us define the targets most accurately and based on the most current information, and I'll show you what I mean by that. But another important function for the most precise treatment of lung tumors is characterizing the motion, because we're always treating moving targets. And now we can compensate for that motion with our plans. And then at the time of treatment delivery itself, using imaging to verify that we're delivering exactly what we think we are, and to compensate if that's not happening at the time. So this was kind of the last generation of conformal treatment. And you can see in those red blobs are involved lymph nodes. And you can see that with using a few beams, radiation is generally shaped to conform to those areas of the tumor, but you can see that there's also a lot of dose spilling out into adjacent areas. The shaping is not that tight, and that also limits how much dose we can give because of how much the normal tissues get. And so intensity modulated radiation therapy, here's just an example of what one beam from an IMRT plan looks like. You'll notice that you see these leaves that are kind of tracking across the target there. Those are computer optimized, creating a pixelated intensity pattern that's computer optimized to create, when all the different directions are added together, dose distributions that look like this. So those lines, you notice, are wrapping around each of those tumor deposits quite conformally. And you can also see that the lower doses are spilling out much less into the surrounding tissues. And you can also see, I'll show you more examples later, but how some of those dose lines are bending around normal structures like the spinal cord. So we're able to do that now with highly conformal radiation. And then the role of imaging has really changed things as well. So we all know the impact that PET-CT has had on the staging of lung cancer. And this is one example of a patient who had apparently early stage disease on a previous diagnostic scan. But when we get scans at the time of radiation, we have an opportunity to see more updated information. So you can see here that the primary tumor has already increased in size somewhat, and we often see that by the time the patients get to us. But in addition, if we have PET at the time of treatment planning, you can see that this sometimes picks up new disease that we were not aware of before, and that, of course, can change the treatment strategy. And various studies have shown that about 20% of the time we have either new targets to treat or actual upstaging by the time patients come to us if we do PET at the time of treatment planning. So radiation planning, PET-CT now allows us to do the most accurate targeting and gives us the most current information. With respect to dealing with moving targets, now we have an array of technologies to do what we call motion management. One of the important things is actually just to characterize the motion that's happening. So 4D CT is one of those technologies that allows us to characterize the way tumors move during the breathing cycle. Then our options, these are just selected options, are to customize the field shape to include all of that motion on an individual tumor basis, or we can gate the treatment by turning on the beam only at certain portions of the breathing cycle, or we can even track the tumor with the beam and follow it during the treatment. So all of these now are options that we use in the clinic. So does this actually make a difference? Well, we have no randomized data, but there are some hints of the benefit. And so this is a retrospective study from MD Anderson comparing the old 3D CT and conformal techniques versus 4D CT planning and IMRT in locally advanced lung cancer. And you can see that with respect to local regional progression, there's an apparent benefit of the IMRT and 4D planning, although it wasn't statistically significant. As expected, no difference in distant metastatic rate. But in terms of overall survival, they actually did show statistically significant benefit. This is non-randomized retrospective comparison, but better survival with the more conformal, better planned radiation treatment, and a pretty big difference in symptomatic or high-grade pneumonitis. So a big part of the effect may actually be coming from toxicity reduction. In terms of data from prospective studies, there was a sub-analysis done of the RTOG 0617 study. Now, this was a study that randomized patients with locally advanced disease between chemoradiation, and it was 60 gray versus 74 gray, and also cetuximab versus no cetuximab. But in that study, although it wasn't randomized, about half of the patients got IMRT versus 3D conformal. And it turned out that there were significantly more 3B disease that were treated with IMRT. So people selected worse cases to treat with IMRT, and yet the analysis of quality of life showed that the quality of life was substantially better with IMRT, indicating that patient-reported outcomes of toxicity is in fact improved with the more conformal therapy. Now, in that study, there was a secondary analysis that showed quality of life corresponded with overall survival. So there's a chance that better patient-reported outcomes actually leads to better survival using these more advanced, more conformal technologies. I'm not going to spend time on this, but now there are, just within NRG oncology, the RTOG, there are now multiple trials ongoing for locally advanced lung cancer. And one of them, the RTOG 1106 study, is specifically asking a radiation question of whether an individually adapted boost to PET-positive disease at mid-treatment will improve outcomes. And then a lot of other trials looking at novel combinations with systemic agents. So let's move on to early stage lung cancer, where there's a lot of data that have come out in recent years. So again, in early stage lung cancer, historically the treatment has been with surgery, and one important phenomenon is what I'll refer to as a potential stage shift that may come about. So we saw that overall outcomes in lung cancer is poor, and that's because most are not diagnosed at early stage. However, if we look at the promising data from the National Lung Screening Trial, this compared low-dose CT screening in high-risk patients, mostly heavy smokers, between low-dose CT and chest radiography. And you can see that actually in both arms, now the majority of patients, or at least the most patients, were diagnosed at early stage. Now compare that again to unscreened patients, where only 15% are diagnosed at localized stage. So there's the potential here of shifting the stage of lung cancer to more curable states. And in fact, that study showed that there was a mortality benefit to the low-dose CT screening. So 20% lung cancer mortality reduction that translated to a 7% all-cause mortality reduction. So that's a bigger impact potentially than any therapy for lung cancer that's been developed in the last 4 decades. So the trend is that the burden of lung cancer will continue to increase, mainly because of the aging of the population and after effects of smoking, even with cessation efforts in the past. And more patients hopefully will have curable disease because of earlier detection. But at the same time, because of those same demographic trends, a larger proportion of these patients will be older and frailer and less able to tolerate invasive therapies. So we do need more and better treatment options for early lung cancer. Surgical resection has been the standard of care, and in patients who can get lobectomy, we've seen better than 70% cure rates. But at least 20% of patients are unable to tolerate surgery because of comorbidities. And in fact, in the US, in community practice, more than a third of patients don't get surgery for various reasons. Historically, the alternative has been conventional radiation, but the outcomes of that have been rather poor. So the populations of patients that we're talking about now are either clearly surgical candidates or sort of borderline or high-risk surgical candidates and outright medically inoperable patients. So the new option that's come from the radiation side is what we refer to as stereotactic ablative radiotherapy, or SABR. So what is it? Many of you now know. It's highly focused radiation concentrated on small tumors with a low dose spilling to the surrounding structures. And the key word here in terms of the intensity of the treatment is biologically effective dose. So we're giving very high BED, and I'll illustrate that in a bit. And this treatment depends on high accuracy and precise delivery. And there's some other terms for this, SBRT, radiosurgery, and so on. So this illustrates the technical difference in how the treatment's delivered. So on the left side is the conventional, what we used to refer to as postage stamp treatment with radiation beams from 2 directions concentrated on that small tumor. Whereas on the other side, you can see the highest dose of the radiation is actually out in the normal tissues in that scenario, whereas on the other side, the more conformal treatment, the highest doses in the tumor. So that creates the possibility of delivering ablative doses of radiation where you can't if your highest doses is in normal tissue. Now, this is a slide from Bob Timmerman, who's one of the pioneers of SABR in the United States. And one of his colleagues asked this question, well, why all this fuss? Can't you just use a postage stamp, deliver a big dose to a small tumor? And unfortunately, that's what his colleague attempted to do, and this is what happened. So when you give these big BEDs, when the normal tissue gets these doses, it can't tolerate it. So it really is different treatment. And so I'd like to say that this is not your father's radiation therapy, and in fact, it's the mother of all BEDs. So this is what it looks like, and now we do these very conformal techniques. So this is an illustration of an arc-based technique to treat this small stage 1 tumor. And this is what it looks like from the point of the view of the machine going around the patient, where you can see this complex shaping that looks like it's covering the projection of the tumor, but there's also a lot of computer optimization going on that helps to focus the treatment so that you can see that dose distribution there on the left. It's kind of molding to the nooks and crannies of our target at the high dose region, but there's an intermediate dose region that comes out, and then you can see how it bends around the spinal cord or other organs that we choose to try to spare. And this is what it looks like from the standpoint of the patient. This is arc-based treatment that's respiratory gated, and you can see the patient's breathing is monitored and that the treatment pauses at certain portions of the breathing cycle. And in terms of outcomes, here's just one illustration showing a couple of patients with both a small and a large tumor. And these are typical responses that we see. About 3 years out, no evidence of disease, complete ablation of the PET activity, and some scar tissue left behind on the CT portion. And so this is an example of a phase 2 study that we're doing of individually dose-adapted treatment tailored to the size and location of the tumor. But in terms of data, there's a lot now, and I'll just kind of skim through it pretty quickly. But now we have lots of data from prospective multi-center trials. So in terms of phase 2 data, the Nordic group, and I'll just focus here on overall survival and local control. These are medically inoperable patients. And so 3-year overall survival was about 60% in the Nordic study and about close to 90% for local control. And you'll see it's a consistent finding. The US RTOG trial, again, 3-year survival of 56%, local control of 98%. And the Japanese cooperative group trial, 3-year survival of 60%, local control of nearly 90%. So those are consistent time and time again for medically inoperable patients. And then in the US, we looked at, this is MD Anderson did an analysis of SEER data, SEER Medicare data, finding, and this is comparative data now of 5 treatments. So lobectomy, sublobar resection, SABR, conventional radiation, and no treatment for early stage lung cancer. And they layer out in terms of outcomes in exactly that order because of patient selection. The healthiest patients are getting surgery and the least healthy patients are getting no therapy. But if you do a risk adapted matching of the groups, you can see these are all comparisons against SABR. Whether it's lobectomy or sublobar resection, there was no statistically different overall survival between SABR and those surgical options. In fact, one could argue that there's maybe even a little bit of decrement early on in the surgical group, whereas compared to conventional radiation, survival was clearly better with SABR, and compared to no treatment, it was clearly better. So SABR has become the standard of care for medically inoperable patients. And then what about operable patients? So this is the phase 2 Japanese cooperative group trial showing 3-year overall survival now of 76%, compared to the 60 or so percent that we see with inoperable patients. So this is now competitive with surgical data and consistent 86% local control rates. And then most recently, this was just published, there are actually randomized data now. This was a pooled analysis of 2 incomplete randomized trials between SABR and lobectomy for stage 1 lung cancer. So the trials individually failed to accrue rapidly enough and did not complete, but I guess the plus side of that is that there's plenty of follow-up on them. And so they were compared about 50 patients, or 58, that you can see that overall survival is actually better in the SABR group, and there were some deaths from perioperative mortality, and local control was excellent in both groups, so provocative data. So in summary, we're seeing consistent outcomes across a series, about 3-year overall survival of nearly 60% in inoperable patients, and 76% to 95% in these trials of operable patients. SABR is clearly superior to conventional treatment, conventional radiation, and should be the standard of care for medically inoperable patients. And it's becoming a reasonable option for high-risk or borderline patients, or patients who just refuse surgery. But of course, more prospective validation is needed, and there are some trials still in the works. So I've run out of time, so I'm not going to go through this last part, but I will just point out that there are emerging data now for the role of radiation therapy in curative treatment, potentially curative treatment of advanced lung cancer. And of course, I'm referring to oligometastatic disease. And then there's kind of interesting data for and concepts, trials under development for oligoprogressive disease. But I think I'm out of time, so I'm just going to stop there, and maybe if there's time for questions, I'll take some.